the sensory motor stage, where the child just through action or through eye contact, you will have to gauge the information. Pre-operational, the child tries to relate the pain or the problem to objects or to example. From concrete operational, which is about 6 or 7 years, the child starts using words, thinking in a logical way. More or less, the child will be able to convey what or why she has come for. You need to know the behavior modification techniques to reduce the anxiety as part of your clinical examination. Most commonly, what we do is your TSD, which is your tell, show, and do. You first tell the child what you want to do, show it on a model or somebody what is going to be done, then finally do it on the child. That's the most commonest thing. Then you have other techniques like bringing in humor or having distraction or bribing the child to have a good behavior, and then finally a systematic desensitization where you expose stressful conditions little by little to the kid. So again, these techniques you need to master or get trained. So with this clinical examination and investigation and history and clinical examination, you go to the third part of pediatric oral medicine practice, which is investigation. Here comes the problem. Nothing can replace a thorough history taking and a clinical examination. 95% of the diagnosis should get complete in that stage. It's only the remaining 5% of investigations has to be done to reinforce your final diagnosis. But unfortunately, in today's practice, when a patient walks in, the younger generation of practitioners, the first thing they have to do is advise an OPG or a CBCT, not knowing for what they are doing it, especially with radiological imaging. Never do it unless it is required. Way back in 2010, we had Professor Farrow, who is the author of the White and Farrow textbook of radiology. He had come to Delhi for a conference. He taught us a workshop on CBCT way back in 2010. He used a very, very beautiful statement. Just because you have a toy in your hand, don't play with it. Know when to play with the toy and when not to play with the toy. So investigations, if it's going to be a radiological investigation, say a CBCT or an MRI or a CT, always liaison with the pediatrician, because the child needs to be sedated for most of those imaging techniques. So combine all your investigations in one go. Suppose you want to do bloods for the child, you want to take a tissue sample, combine everything in one thing. Don't have a separate sedation for an imaging, a separate sedation for bloods. So get into the habit of teamwork. If you want to walk fast, you can walk alone. But if you want to walk far in your life, you have to walk with people. So get into the habit of doing a teamwork. So liaison, try to combine all procedures when the kid is sedated. I want to emphasize on the next 2 slides on the role of radiology. Even though it's oral medicine, radiology is integral part of oral medicine practice. The only X-ray which is permitted as per the American Academy of Radiology and the European Association of Maxillofacial Radiology, at least in pediatric imaging, is a bite-wing X-ray to look at the proximal and the occlusal caries. Not much of periapical lesions you are going to encounter. If it is clinically, yes, then you take a periapical. If it's going to be just caries assessment, you will have to do only a bite-wing. And there is a time limit given for each bite-wing X-ray. Any idea what's the time limit? 0 or 1 to 3 years or 3 to 5 years. Clinically, if the child is not prone to caries, then no X-ray at all. If there is an enamel caries, you can take 1 bite-wing in 1 year, not during each visit. 1 bite-wing in 1 year. If the child is caries prone, say more of dentinal caries or more of a pulpal involvement, then once in 6 months, yes, you can take a ring. But between the age of 9 to 11, there is no indication for X-ray because the teeth are going to exfoliate and the permanent ones are going to come. So depending on the clinical assessment of the caries state of the child, you take a decision on when to take an X-ray. Taking an X-ray, as you know, it's based on the concept of ALARA, which is as low as reasonably achievable. Now it has been changed. It's called ALADA, as low as diagnostically acceptable. They have also added a clause to it: patient cooperation or patient needs. So you are justified to take an X-ray if it's going to give you a little more of information which you did not get in your history taking or clinical examination. If you say yes, then you proceed to the next step. Optimization. Just because you have an IOPA, you have a bite ring, you have a panoramic, you have a CEF, don't subject the child to everything. Think which X-ray is going to give the maximum diagnostic information, and then you go with that X-ray. Third thing is, if the child is not cooperative, don't proceed with it. Finally, limitation. Here comes your radiation protection. Always have only that area to be taken. A maxillofacial radiologist would know. We get requisition, advised OPG, name of the child, age, advised OPG. For what purpose is OPG required? What is the clinical history? So if you are referring to a radiology center, kindly give a little bit of history to the radio technician or to the radiologist, because we would be able to serve you better. The lesion might be in the first molar region in the lower jaw. So why do you want to expose the maxilla or the left lower jaw? Even in current panoramic machines, we have segmental imaging. Only that area can be exposed, better diagnostic information. So you are going to advise an OPG, we are going to give an OPG with a gross description. So you specify it, we will be able to give you a better radiological diagnosis. Use the fastest speed film or use digital films. This is the time period I told. Now the practice in the Western world is, for caries detection, they are going for non-radiographical based investigative procedures. So you take a radiograph only if your non-radiological investigating procedures like an optical light or an optical coherence camera is not picking up the lesion, but you suspect it. So this is about radiology. CBCT. I purposely put it on both sides so that you reinforce it. Today the practice is to advise CBCT for pediatric population. No. Unless it is a trauma or a developmental disorder or a cyst and a tumor, not for an endodontic treatment or not for a caries assessment, never do it. Do you know how much one CBCT exposure? It's less. Even for adults, one CT exposure is equal to 300 OPGs taken one shot for a patient. So that amount of radiation you are going to give to the patient, not to a child, unless it is deemed mandatory. Even if you want a CBCT, all machines, we have a CBCT machine is divided into three: a small FOV, a mid FOV, and a large FOV. So we will go for the small